everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Amwell. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion, and we'll get to them at the end. Afterwards, stay on for an interactive and unique virtual mind reading show with the mind-blowing mentalist Mark Toland. And with that, I'll throw it over to our moderator who joins us from Amwell, Roy Schoenberg.
Thank you for the introduction, and thank you everybody for joining us. Hopefully everybody got in and can hear the sounds and see everybody that's joining us through this video conferencing. I first want to start by actually giving a shout out to Health for the initiative of bringing us all together. The reality is that we're all with our heads down, usually from the back of the kitchen table or the attic or the basement, trying to do all the things that we need to do at a time of isolation and shelter in place, that it is almost impossible to think about how we can all get together and share the information and the lessons learned during the time of COVID. So the initiative of Health to make that happen, and I know that there's a lot of people that have joined us, is truly something that needs to be recognized. We want to be thankful for that. We have a packed agenda and a lot of very, very relevant topics, but I just want to start by saying that just to get a sense of how meaningful the transformation that we're going through is, when I think about it, I actually want to share the fact that I had the privilege last evening to actually head out of home and go and have dinner with my wife and a couple of friends at a restaurant in front of the waterfront in Boston, which was the first day that we were allowed to do that. And it occurred to me as we're sitting there and having a dinner and a glass of wine, that what we were actually doing is celebrating the fact that we're able to have dinner, which if we were thinking about that 3 months ago would have sounded completely insane, but this is the reality that we're undergoing. And it kind of highlights in more than anything else, how significant the change is and how significant the response to that change must be. And that is the topic of the conversation we're having today. Before we jump in, I want to take the opportunity to kind of invite to our electronic stage the panelists that we have together with us. And I want to start by just introducing them by alphabetic order, for lack of any other kind of order. First of all, we're delighted to have Amy Quirk with us. Amy is the CEO of Innovation Ochsner for Friends and Family IO. That's the kind of the internal name, which was really founded about 5 years ago by Ochsner Health, with a charter to truly reimagine the delivery and reach of healthcare and healthcare experience itself. A very, very noble, novel charter. IO focuses on multiple dimensions of care delivery, and it goes all the way from the very, very subjective human experience with healthcare to the very, very objective other end of the spectrum of data and analytics behind it. Amy brings to the panel a very uniquely diverse world of experiences that span not only innovation in itself, but also a lot of activity around law, healthcare, economics, public service, both in operational and in policy roles. So I'd like to welcome to the stage Amy from Ochsner. Our second panelist that also probably requires no introduction is Darren Twerking. And Darren is the CIO at Cedars-Sinai, which again, I think is an institution everybody is very familiar with. Darren, to his name, you can tie and affiliate massive, very, very successful technology journeys, including organizational embrace around everything digital, from EHR implementation, which as we know is not for the faint of heart, to everything at the level of the point of care and literally everything in between in terms of digital embrace and transformation. He's also a repeat offender, maybe that's the way to describe it. He has done that not only at Cedars-Sinai, but also previously has done that at Boston Medical Center, where he served as a CTO. To top this off, he also, if he has spare time, Darren is also an entrepreneurial leader, both inside Cedars-Sinai as running their accelerator, but also as a founder of his own analytic company, Stanton Health, and as an advisor and board member in many, many healthcare entities and organizations, many of whom are very familiar to the audience that we have here. And last but not least, I want to welcome to the stage Roberto. Roberto Schwartz is the EVP and Chief Innovation Officer at Houston Methodist, which I think everybody knows is kind of the leading health system organization in the south of the country for many, many years in a row by most publications out there. It sits consistently at the top of that region. Those of us who know and are lucky to know and work with Roberta have a very, very deep appreciation to the role model, not only the role, but the role model that she is in driving relentlessly Houston Methodist boundaries, the ability and their ability to modernize and improve care delivery. From their Model Innovation Lab, which if you have not visited, I would solicit that you ask for an invitation to go and see, to the bedside at Houston Methodist. Roberta is usually the force behind all of these changes. She's known to leave no stone unturned. Telehealth, AI, analytics, I'm pretty sure there are many, many other technologies that Roberta masters and puts together to the work of Houston Methodist, and literally every cross point between people and technology in healthcare. This is also fueled by an incredibly rich professional know-how that was gained previously, prior to Houston Methodist, in places like Mount Sinai in New York, advising CMS, working in Johns Hopkins, and quite a few several nonprofit organizations around along the way. All this makes Roberta a true authority in this field. So with this kind of rock star panel, my job becomes really easy. I should pretty much kind of speak less and let them, tell you the stories of their institutions and organizations. And I'm going to try and do just that. But as we dive in, we thought that before we open up a conversation around everything that has to do with the response and re-architecting of institutions with technology around COVID, we thought it would be useful to share with you just a brief lens, from the brief lens of each and every one of us, what COVID translated into by way of really trying to architect and respond to, to the last couple of months. I'm going to be very brief about it. I think, when it comes to telehealth, I think nobody needs any introduction. Telehealth has gone to center stage, from the very beginning, even by mention at the Rose Garden and everything that fell from, from there, as a true technological counterpart to the ability to deliver physical care that was severely challenged during this period. I don't think we need to go into any one of the different statistics that you see on stage, but the sheer number of zeros associated with any one of these charts that speak to the inbound traffic of patients, the rapid evolution of telehealth with clinicians, the different use cases, and also just the different kind of heat points along the country as COVID was moving from one epicenter to another, probably gives you a visceral understanding of how the reality inside Amwell has changed over the last couple of months. But if you go into the next slide, there's been a lot of different statistics. This is to me the slide that really kind of best primes the conversation that we're going to have today. It's actually a very simple one. It speaks to the volume of telehealth that that we've seen on some of our servers around the country, and it kind of spans the time from the beginning of the year to roughly where we are now. But the part that is really interesting is that if you kind of broadly divide the world of telehealth into telehealth that's being used for on demand, essentially where patients who are maybe stuck at home and have no place to go raise their hand and say, I need healthcare. That's kind of the greenish or yellow greenish part of that slide. And you also look at the volume of follow-up telehealth, which was historically not the presenting type of telehealth. Urgent care, on-demand urgent care has always been the kind of the way people understood telehealth to be. Follow-up telehealth, which is the picking up of telehealth by clinicians, by physicians primarily in health systems and group practices, and using it in order to interact and manage the patients that they already have a relationship with. You can pretty much see how history changed roughly at the beginning of April. This was the point, and in my mind, I don't think this is ever coming back. This was the point where the telehealth volume completely reinvented itself with the understanding that telehealth and other technologies are going to be embraced in a very different kind of way in order to manage our responsibility as healthcare professionals and healthcare operators to deal with our patients. And the reality is that these trends that we're seeing here, where history changed and continue to grow, are continuing to escalate on a daily basis. So this is, kind of a good springboard to hand it over to our panelists to talk a little bit about the reality that they have seen in their organization, and then we'll dive into more specific questions about re-architecting using technology. So I want to hand it over. I believe that Amy, you're the first one that is going in.
Great. Thanks, Roy, and thanks to the health team for organizing this. That was a great lead-in. As we look back at the last 3 months, it's just staggering the amount of work. And what I wanted to do today is just kind of share with you briefly our experience of the last 3 months. We got our first patient in Louisiana March 9th. So we were kind of on the early end. In fact, we were one of the early hotspots. We experienced a rapid rate of rise and hit our peak mid-April. To date in Louisiana, we've had about 44,000 cases, over 2,800 deaths. Osher and Osher Health, we are the largest health provider in the state of Louisiana, and we've treated about 30% of the cases. And in the greater New Orleans area, where the peak was the greatest at the beginning, we treated about 60% of the critically ill COVID-19 patients. And it was quite a burden in those initial weeks to adapt quickly. But fortunately, our team is tried and true kind of at every level, from the front line to our leadership. We've gone through a number of challenges with hurricanes and oil spills, you name it. And so that type of resilience kind of helped us galvanize quickly on a response. So if we look at just kind of our operational response, and this is just intended to represent some of the highlights and work that was done in that period. Can't capture everything, but one, just got to give kudos to all of our operations team. And basically in the first 2 weeks of the pandemic, the teams expanded capacity for our ICU beds as well as our EICUs to allow for more remote monitoring. We accelerated internal testing. As you guys remember at the beginning, test results weren't coming back quickly at all, and our team moved fast to be able to bring in testing in-house, and we've now provided about 30% of the testing in the state, and keep doing more of that. And our state happens to be one of the states with the highest per capita testing rates. We're in the top 10. Two things that we were able to do for patient safety and for the safety of our teams is we built on an innovation called Optimal Hospital, which is something that our team at IO did, which was to recreate the experience in the hospital. And we brought on continuous vitals monitors so that we could be continuously monitoring vitals of patients while limiting exposure to the beds, and because we had relationships to patients rather, and because we had relationships with those vendors, we were able to bring on a large number of those remote monitors technology in a very short period of time. Copper is naturally antimicrobial and virucidal, and so we were able to introduce that both for bedside tables, for linens, for everything, and we converted about 1,200 beds in 7 days to try to provide another layer of protection for our teams. We created a number of patient resources, everything from a hotline to a text-based symptom checker, to iPads in rooms to facilitate communication, and did a great job supporting our employees with childcare, et cetera, et cetera. So that's just a couple of things that happened in those 2 weeks. That was augmented by some of our existing innovation research capabilities. And again, a couple of highlights. In the first couple of days, we realized that PPE was going to be an issue. And so we capitalized on the expertise of our innovation engineering team on rapid prototyping. They use 3D printing and other types of prototyping skills to design and then bring to scale, manufacture at scale, about 12 different products. that are in active circulation. That's an ongoing effort and something that was really incredible to watch. Our team also worked to create a testing registry, which was really important to understand where the positive and negative results are and create a single source of truth. That was something the team jumped into right away and was a great service. And at the same time, kind of really thinking about what are those hot spots and blind spots that we need to really focus on testing so that we can focus on containment. Our team also developed predictive models for capacity planning. Our team has got a strong backbone in AI and ML expertise, and some of these things were done before the storm, but I call it the storm because that's what we tend to call it here in New Orleans, but before the pandemic. So on vent use, bed use, outcomes, and length of stay. And then in the area of testing, we've got about 15 testing teams out there doing walk-up neighborhood testing with translators, easy access, making sure that we're able to reach vulnerable neighborhoods and make sure that that we're making sure that we understand where the need is and how the community is doing. And then finally, our research team launched a prevalence study, really incredible study, where they tested about 2,500 individuals over about 5 days in 2 parishes. We call them parishes here instead of counties, to really understand the true prevalence in the communities. And that's a paper that's been submitted for publication. Excited about seeing the results of that, but that was both a PCR and a serology test, and it will be very insightful. And then finally, all the while, Ochsner has been an early pioneer in adopting virtual care. And we've been working on this for many, many years. And it was fortunate that we had a lot of pieces in place because true to what Roy showed with some of the data that he had, we saw an absolute explosion of interest in virtual care. And we were grateful and fortunate that we had a lot of infrastructure in place to be able to provide that service and provide that service both to patients who wanted it and to the providers who wanted to be able to offer that service. It made a lot of sense. In the telehealth visits, both urgent care and virtual visits, we saw last year we had 3,500 visits in a year. And in that time, we are about 4,000 a day. So that's quite a shift in terms of those metrics. They've blown that goal out of the water. We also have created some solutions for chronic disease management. This is a continuous care model that really looks at a complete picture of health, at social determinants, and uses connected devices, blood pressure cuffs, glucometers, so that we can understand how patients are doing at home. So it's always been a program that's fully based at home, but gives us better information and a better opportunity to intervene with patients and help them maintain disease control. It's been a very successful program clinically, cost-wise, and in terms of experience. We saw 40% enrollment growth in that. And those programs, similarly, we have a program for pregnancy for moms who are expecting, and it allows us by use of a scale and a cuff, blood pressure cuff, we're able to understand how mom's doing at home, and if she's doing okay, she doesn't need to come in. And if there are warning signs we know earlier, it works wonderful in peacetime, but in the middle of a pandemic, it's brilliant because it allows mom to not have to come in so much, but still receive the high level of care that she's used to. And so all of these solutions saw just tremendous growth, and it was just a testament to the work that we've been doing over the last several years to make sure that we have these digital solutions, because we knew that they would be more effective, provide a better experience of care. And turns out in a pandemic, they sometimes provide the only care that's available. And lastly, we recently launched another remote care program for COVID-19 that allows us to monitor vitals at home and understand how patients are doing at home, just to make sure that we're able to get that visibility. So this is just a snapshot of a few things that were done in that time period. It's really incredible work, and I'm just proud of the work of the team and our entire system for pulling together and getting all this done.
Terrific. Thank you, Amy. We'll get back to many of those points. Darren?
Sure. Amy, that was great. I was tired just looking at all the items. I can only imagine what it was like to implement those. Thank you, Health, for having this event. I feel like this is my big day out today. It's still middle of the day here in LA. I even got dressed, half for the reason of being appropriate for this presentation, the other half to make sure real clothes still fit me. So I'm just happy to be here. You know, Cedars has a similar story, you know, both in terms of reacting to the crisis as well as our efforts to serve our community. I'll start by saying that, you know, it was one of those times where, you know, being the leader of the IT team at Cedars, I've been in the role as CIO for the last dozen years or so. I couldn't have been prouder to really watch the IT team sort of step up and react and be able to serve our clinicians whose mission it was to serve the community. They did things that truly amazed me. I likened it to one of the many, many go-lives that we typically have, in that it's always an amazing time to watch people come together, barriers to come down quickly, and folks just figure out how to get things done without you know, some of the normal day-to-day meetings or otherwise processes that sometimes are put in place. And the agility that the team showed was really amazing. We did quite a bit, as most organizations figured out how to do across the country. A lot of it, frankly, was really adapting to how we configured a lot of our core systems. We use Epic as our electronic medical record. I probably would not be exaggerating if I said sometimes we schedule projects that last 2, 3, 4, 5, 6 months in terms of reconfiguring optimizations or how units are set up. We did those things in hours, maybe sometimes in days, reacting to how we wanted to rethink how the clinical enterprise needed to look from the ambulatory side all the way to the inpatient. We spent a lot of time really delivering information. I think for us at Cedars, it really was a coming of age in terms of, for one of the really first times, we moved to agile use of data at the time it was needed. We converted most decision-making to leveraging real-time dashboards. And if I thought of one or two things that I really hope sticks, or as the big lessons learned from this, I really hope our organization's use of data, real-time data, at the time of decision-making is something that really is beginning to sort of carry through. It was not long ago that I visited Amy's command center that they set up in terms of bringing real information for decision-making in terms of placing patients. That was very new to us. We stood that up again in the matter of days and weeks to be able to move towards that. Of course, I would be remiss if I didn't mention that we went from, on average, about 400 remote workers to 4,000. That was interesting. Not quite sure if we're ever going to get some of them to come back to the office. That will be a different discussion for the different day. Amazing things happened with regards to testing and our clinical delivery. But the part that I thought I would sort of focus on is a piece that Roy touched on that clearly they've seen across the Amwell network. And that was, we loved our pilots at Cedars, and we sort of insisted and believed that almost everything big needed to start first with a pilot. The graph that you see up here was one that I had put together for me. It's a collection of all of our surgical practices and the percentage in their use of follow-up video visits. And you can see in looking at that, that in January and February, it was essentially zero or small enough not even to sort of make the graph. As March sort of came to be and a new reality was sort of setting in, telephone visits began to be experimented with. And then you can see sort of the growth of video visits. And I think it's really sort of a great example of when we talk to the surgeons and the surgical offices and try to sort of understand, you know, how they're using video versus telephone versus still, of course, some very necessary face-to-face or in-person. It's really interesting to learn and to be able to sort of build from a bunch of experiments that we otherwise wouldn't have run. And so what could we do to support that at scale? And the truth is that it's really reinforced for us that we had a very big, ambitious plan around a digital front door that included a lot more than just video visits, triaging, synchronous video visits, asynchronous visits, talking, texting, finding a doctor, scheduling, how to engage and educate, monitoring devices at home. We knew that all of those things had to sort of come together in sort of one platform. And I think that what's amazing to us now is even with us still managing through the crisis and managing through some of the uncertainty ahead, the engagement of our clinical and operational teams, really with their commitment to understand that the digital front door is something that we have to accelerate, is really sort of refreshing to see. And so I know that we're not by any way stretch of the imagination sort of through all of this, but it is encouraging to know that many of the things that we jumped into, many of the things that we have delivered for the organization are going to have a really lasting effect in terms of how Cedars-Sinai looks going forward.
Terrific. Thank you, Darren. Roberto. Roberto, I think you may be on mute.
I am so sorry. There we are. I feel very blessed to actually be both with the panelists and with Roy. We have so much in common, which makes this such a pleasure. It also allows for some good dialogue as we learn from each other, as well as learn from all of you within the chat. So our story, I would tell you, this is not everything, but it at least provides some breadth of experiences, much like you've heard before, of the different ways in which we use technology. One of my most favorite meetings was right at the beginning when we gathered everyone in the Center for Innovation at the table, and we said, okay, everyone, tell me every vendor that we already have, every technology that we already own, and basically tell me every way that we're going to deploy that technology for everything that is about to hit us. And we just turned ever so slightly in what was already a very agile speedboat and kind of turned it. And I'm very thankful for everyone on what we deem our DIAPA, Digital Innovation Obsessed People group, who took on the challenge and trained hundreds of physicians and deployed thousands of iPads and really brought the technologies very quickly to the bedside. Our story on telemedicine, we can all just overlay every one of our charts onto what Roy showed. It was beautiful. I would tell you, I watched institutions that didn't already have the technology in place struggle a little bit, while those of us who really had made leaps and investments in advance, really able to just turn this on, train the remainder of physicians and kind of move forward. So I think we'll all talk a lot about that as the absolute success story. Really, I view what might have taken us 5 years turned on in 2 months. And the question is, where will it land after we start back seeing all of the patients in person in the same way? Care pathways, I can't help but talk about how successful care pathways were. When you have a really solid care pathway program, we were able to turn on over 7 care pathways in COVID with the patients leaving the hospital. This allowed a number of patients who really felt like they had a scarlet letter and were quarantined and were put aside to really keep in touch with us and feel like they had a lifeline to the medical community, even if they weren't in the hospital. Robotic process automation, many of us turned RPA on to new and innovative areas very quickly and programmed. This was actually one of our bots that looked at the CARES Act to make sure that we had all of the information submitted correctly to the CARES Act. And bots, whether we talk about chat bots, whether we talk about internet bots, lots of different bots in different systems were deployed. We use them both on the phone as well as symptom checkers, I would view as a different kind of bot. And one of my favorite bots that we turned on very quickly in Syllable was actually to screen those patients who were going to give blood in convalescent blood therapy and really look at the ways that we could make sure that we were getting to the clinical coordinators, just those people who were ready to actually donate blood. And then all of us would really speak about patient engagement. In rooms that we weren't able to go into a lot, you needed to really have patient engagement tools for people to keep in touch with their families, for doctors to keep in touch with patients, and to keep the patients entertained when we weren't allowed to have visitors in. So whether it was Alexa devices, iPad or tablet type of devices, information even for our employees over the internet, intranet, and mobile devices. I think this plethora of opportunities was used to actually bring innovation and innovative technologies into the bedside. Whether you want to call these innovative technologies or those that healthcare is just catching up to, I was really ever so proud, like Amy said, of everything that we were doing to bring these technologies to the bedside. And I know, Roy, you're ready for a very strong dialogue between all of us, so I'll just stop there and turn it back over to the dialogue.
Terrific. Thank you, Roberta. Wanted to make sure that I'm not on mute either. So as we can see already from the Q&A that is coming in, you know, there's so much to talk about in so little time, but I want to try and kind of go into some of the elements of what happened and how they actually ended up impacting our ability to re-architect or modernize how we do care delivery. And I want to actually start with Amy, with you. You know, one of the realities of Ochsner being in, you know, primarily in Louisiana was that you were one of the epicenters. You know, the more than in other places around the country, the steep growth of COVID infection in Louisiana, in New Orleans, has been, I think, second only to New York. And interestingly enough, I wondered if when we talk about re-architecting, all of those incredible changes that made Darren, you know, tired just to look at the entire list of the things that you brought up that you made happen. Can you talk to us a little bit about how you correlated, in a way, the sense of urgency that was very evident in Louisiana to the ability to make changes and re-architect, or maybe differently stated, was it actually easier to re-architect your system under fire than it was in peace times?
So there are a couple ways to answer that question. I think the extent of the issue was huge, and it was rapidly changing. You know, in those initial weeks, right, the guidance was changing daily. What the expectations were was changing all the time. I said, you know, we went into it with a really strong team, tested many, many times from our leadership to the front line. And that allows us to be agile and strong and resilient. So that's number one. And that gave us an advantage, even as we were going through that uncertainty. And, you know, and two, we all had a common mission to serve our community and to serve the patients. And that focus, you know, we've all kind of reflected back. How do you keep that in a bottle, right? That focus, that singular focus, even though we were all doing different things, whether it was supply chain or our frontline teams or our HR teams or the clinical folks or infection control. I mean, everybody was focused. And so Darren mentioned, you know, you could make decisions, things that might take months or even longer, you know, could happen in minutes or hours. And so, you know, it was that focus that made it happen. And because we knew we were fighting for our community. So, you know, it is easier in that sense, right? I mean, I think the work was pretty overwhelming when you look back on it, but the focus that everybody had, that singular focus that everybody had, made a big difference. That's probably true of the others as well, I would imagine.
Yeah, it certainly has been true sort of at Cedars, but I'll tell you, there's an interesting sort of side effect that we're trying to grapple with now. And I'll give an example. I had a meeting this morning with the leader of our largest hospital and our ambulatory group, and they both started off with seemingly complimenting the IT team of how quickly we were able to react to things. But before long, I realized what it really was, well, since we got that done so quickly, how come we can't get the next thing done so quickly? And I think that it really is, you know, the power of when the entire organization is focused on one thing. And I think that a lot of our organizations sometimes have many first priorities. And so it was interesting to watch that happen. The other piece that we're finding ourselves right now, and I don't know whether Amy and Roberto, you guys are finding this, but we're having to double back a little bit. And some of the things that were the exact right answer with no regrets in time of crisis might need to be hardened a little bit or perhaps enhanced a little bit if we're going to keep them around for perhaps more than a week or two.
So Darren, you're not the mind show after this panel, but you did kind of somehow figure out what was going to ask you, next, but essentially a follow-on to exactly what you just said. We've all experienced the deep desire to roll in a lot of technologies very quickly on a lot of different fronts, telehealth and otherwise. Have you seen that the reality of COVID changed a little bit the mentality of the institution by way of, was it better to roll out things fast and fail forward like the Google mantra? Or do you think that it is still better, in hindsight, to look at slow and steady by way of deploying technology? There's advantages and disadvantages for both.
I would tell you that for all of us who are innovators, and I don't know if I speak on behalf of you, so Amy and Darren, I would love to hear your answers. This was fabulous. This was amazing to watch. The confluence of what we saw so quickly, the things that we dreamed. We would go to the health conference and say, maybe in 5 years, we'll have everyone buy into this technology, and to have them go, bring it on now. Like, how do I get trained? Oh my God, to have them pull it rather than us push it was absolutely amazing. It was such a beautiful thing to watch. At the same time, in our world, it's 3 steps forward and 3 steps back, 2 steps back, 1 step back. Wait a second, did we check the security on that? Are we going to do that? I think that's what Darren's talking about, right? There are some places where, both on a technological front, we may have skipped the rules. So you have to double back and do that. But at the same time, the physicians, we pushed things forward, and all the payers were paying for it, and the government was paying for it. And now that the payers are saying, hey, wait a second, we may be turning that payment off. The question is, well, does that turn off the pipeline, and what are the impacts of that? So I think now we're trying to figure out what the new normal will be for some of these technologies. Is it going to be as much as 70% where it was before, or is it going to settle out in the 30%? And what is the going forward piece of the business, whether it's telemedicine or whether it's patient, engagement in the rooms, whether it's the PPE that we put in? Where's that new normal going to be for the next year and a half when this is an ongoing basis rather than that 2-month emergency?
So along those lines, and I think, Roberto, you're in a perfect position to answer this question. When we always think about innovation in healthcare, there's always a very healthy friction between the new thing at the edge of the envelope and the relatively conservative nature of medical practice that, rightfully so, needs to take a very kind of healthy grain of salt with everything that it embraces. Do you think that coming out of COVID with the dividends that were clear for rethinking about the balance between digital care of patients versus physical care of patients, do you think we're going to be in a different place? Do you think that it is possible that the practice of medicine will rethink the way it balances itself between digital and physical?
I would say, and I, again, would love, to point that over to all of us. I think we hit, you showed the lines crossing, and without a doubt, I think we reached that tipping point. I think consumers actually tried this out. And in our marketplace, I would speak to the fact of urgent care. We have a lot of urgent care in various strip malls and all kinds of places. They're not seeing the patients come back at the same rate as they were before because patients discovered virtual medicine. When it comes to patient engagement, the physicians coming into the room or the patients basically engaging their families via an iPad rather than all of those families streaming into the medical center, that changed. When it came to our staff adopting different ways of getting in touch with doctors, whether it's chat or all kinds of new tech, that changed. And I think that I do think we're all at a point of not returning. And Darren and Amy, what do you think? I mean, I don't think there's a coming back from this to zero, ground zero again. I think there's a new state.
I agree. I think there will always be a mix of bricks and mortar and digital. But I think what we saw in these last 3 months and what that did, the tailwind it provided for everything virtual. I mean, Roberto said very well how patients want it now and experienced it and are sticking with it or seem to be. But just as importantly, providers did too, right? And so they were kind of forced into doing it. And, you know, we had it was going to be a slow ramp because of both of those things. And we saw behavior change on both ends. And so I think that's a really strong signal. And I saw that Seema Verma, you know, gave an interview last night where she said, you know, she thinks it's here to stay, and they're going to be looking at how do they maintain the reimbursement for some of the telehealth. That, you know, she left it open whether that'd be parity, but she shared that, you know, she really does see it as here to stay, and I think that's a positive sign. Certainly, I think our providers want it, and our patients want it.
Yeah, there's little doubt in our mind that, you know, we all ended up running a large experiment we didn't really want to run. But now, having run the experiment, you know, it's clear that, you know, we've discovered a new reality around it. I think the piece that, you know, we'll have to watch carefully is that, you know, video visits or telemedicine isn't a single thing. And in the same way that, you know, we've spent a lot of time thinking about how to deliver each type of ambulatory practice that we do, whether it's urgent care or surgical follow-up and sort of everything sort of in between. I think that we're going to get different answers for video in each one of those settings. And what's been interesting for us to watch in just a little amount of time has been that patient preference is actually swinging in two different ways. So, you know, there's some visits that our patients are clearly indicating they never want to come back into the office for. And by the way, some of our physicians don't want to leave the home for. They want to sort of continue in the way they are. But then there's others where patients are, listen, I understood the urgency and the safety involved, but I want to go back and see my doctor. And so it'll be interesting to sort of see how some of that shakes out. And I think our belief is that we're going to have to be, unfortunately, a lot more detailed as we work with each of our ambulatory areas, as opposed to sort of this overlay idea that was part of the ease of the rush as we converted to the reaction to COVID.
And picking up, I think, on Darren, what you said on this, both double backing as well as organizing our visits, what we found that we were doing was a very one-on-one experiment, one doctor on one patient. Right. And we all sent our MAs home, and we all sent our, you know, all of the support staff home. And one of the things that those MAs do as the doctor leaves the office is say, hey, you need this test, you need this lab, you need this, you know, you need all of those things organized. And they're the organizers behind it. So when the physician would leave the room, it didn't necessarily get the rest of the needs organized. And I think in double backing, Sarah Pletcher, who's really stepped in for us on telemedicine, would really tell us that we really probably need to go back and do that reorganization on the ambulatory level to make sure that everyone has what they need. And that's different from what I would say is the patient engagement, where I'm very jealous of the place that Darren was before COVID, and we got there very quickly. And Amy, you'd have to speak about where you are, which is an iPad in every room and an Alexa in the rooms. And really now we're taking everything we had to push in very quickly and saying, oh no, we're going one-on-one, because, you know, that technology just, it's a table stakes at this point to have them in the room.
So if you think about the world outside, you know, the rules of the emergencies, you know, the emergency reality are going to be lifted. Knowing everything that you know now about what you can do with those kind of technologies, what from the outside needs to change to allow you to then take and magnify the things that worked, things like Medicare coverage for treating patients at home using technology. You know, definitely some of the HIPAA restrictions around modalities that, you know, to some degree have been eliminated but are roaring back, or the rumor is that some of them are roaring back. Clearly there were examples around state licensure that, you know, have been very relaxed in places like New York that changed the availability of care. What would your ask be for the outside world, for regulators, for payers, to allow you to take advantage of the lessons and amplify them?
I can start. Or you got it, Roberto.
No, go ahead.
I think my ask would be, we've talked some, there's a lot of aspects of virtual care, right? There's the episodic synchronous visits, but a lot of work that we've done has been in remote patient monitoring or remote really care that is a continuous care model. And of course, there are there are codes and ways for that to be reimbursed. They don't really match with the value. And yet we saw that in the midst of the pandemic, those programs kept running and in fact exploded with interest. And we also know that those types of programs, when it comes to chronic disease, reduce costs, you see better health outcomes, better satisfaction experience by both providers. And so it's like the value is there, but the reimbursement doesn't really line up with that value. And I think what the last 3 months have shown us is there's a lot of need and interest to be able to keep those types of programs going. And we really need to think about how we design and incentivize that type of redesigned continuous care model that doesn't just depend on episodic visits, particularly for chronic conditions. And of course, as we know, in this pandemic, that the most vulnerable communities are people with chronic conditions. And so that's just one more reason, among many others, why we really do need to be thinking about how do we really redesign care and support these continuous care models.
If I had an ask, certainly from regulators or those type of people, it would be to look at the virtual space, the remote monitoring space, and look at reimbursement levels and kind of what the right answer is, and get us those answers as quickly as possible so that we could build programs around them. But I would also ask from both the provider community as well as the innovation and IT community to really quickly, basically nationally, as quick as we can, look at best practices, what worked, what didn't work, even if we know they weren't the most perfect of experiments because it wasn't prospectively designed. But I think if I had all the cardiologists get together or all the OBs get together or all the everything in various societies and say, from a telemedicine, from a care pathway, from a bot perspective, from an everything, what were the 30, 40, 50 things that worked? We could all go back, because there is going to be a second wave and a third wave. We're in the middle of wave 2 right now, expecting probably to go up to close to where our first wave was. So there are going to be these kind of continual ups and downs. So if I can learn the lessons nationally and apply it very quickly to wave 2, 3, and 4, I think we'll all be better off for it.
So Darren, this is a good one for you, because California has kind of slightly been, more successful than others to not get as many, patients on exposure. If September comes in and there's a second wave, are we better prepared? Are we not going to be in a position of shame me twice?
I certainly think so. And look, I think that the difficulty that we're in now, and I think many folks are across the country are in sort of the same spot, is we sort of find ourselves in between, right? So we're not finished reacting to the crisis, yet we're starting to plan for sort of the new reality and just sort of hyper aware of we're going to live in this sort of in-between space for a little bit. And I think that, the interesting phenomena that we're grappling with is, early on, somebody pointed out to a group of us that we readily use the word elective procedures and elective surgery. And it's sort of this well-known sort of industry term within sort of healthcare. But to patients and families, they really don't think of a lot of that stuff as elective. We delayed a lot of procedures and surgeries, rightly so, when the crisis first hit. And we asked our clinical leaders to help make decisions of which things can get pushed out, which turned out to be a lot of things. But those decisions they made that were things you can push out a week or two at the beginning are not the same decisions they had when it was a month later or 2 months later or approaching 3 months later. And so I think the interesting conundrum we're going to have now is that we have a lot of care for the community that all of our institutions provide that doesn't really go away. And then you have to layer on that sort of these waves of COVID activity. And so, it's maybe a long way around of getting to what worries us about the second wave is not just the potential height of it, but the pent up demand of care for the community that was delayed from that first wave. And when you start to add those together, we're really starting to try to understand what our surge numbers might look like.
So I think, that kind of leads to a very fundamental question when we think about the silver lining of all of this. If there is a silver lining for a pandemic, which probably many would say no, but can we as individuals expect growing old at home differently because these technologies have reshuffled our understanding of where healthcare should or could happen? Is it safe for us to be optimistically expecting that that is going to change and we can maybe gracefully age or spend more of our time where we want to be in the home rather than where we need to be, which is inside the belly of the beast of the healthcare system? Is that tied into what we've just seen?
Absolutely. I think we're well on our way there with delivering healthcare in the home through all these various modalities that we've been talking about, and then more to come, right? And when you start thinking about how do you add in passive monitors and things like that to be able to help provide support and to help keep people at home as they age. I think one of the areas that though that we're going to need to look at in that, both for aging populations as well as vulnerable populations, just how do we really think about the digital divide that exists? While we see great penetration in a smartphone adoption, for example, 81% of Americans have it. I think, the areas where they don't have it are the more vulnerable populations of the community. And where there could be aging populations or communities of color, people with language barriers, et cetera, et cetera. And we know that a lot of these digital technologies allowing people to stay at home eliminate some of these transportation barriers and other types of barriers that may exist to accessing care. But I think some of the work that we need to all do intentionally as a community is really think about how do we advance the digital divide to make sure that we're caring for vulnerable populations through all of these technologies as we go forward.
I think you started out this panel with how excited you were to go out to dinner, and now you're asking to gracefully grow old at home. I'm not sure which one it is actually, but I would tell you one of the success stories, if you really look at it, is everyone really wanted the nursing homes and the assisted living facilities to kind of remain shut down and not to transfer those patients back and forth. And so some of the digital technologies that they utilized to kind of keep in touch with physicians and make sure that they were monitored was actually really impressive when you look at that population. Everyone was so scared of COVID getting into a nursing home and what that would explode and what that would do to ventilator use. So I think finding that new relationship with different groups of aging Americans was really very important. And I think one of the success stories, if you really look at it, is really the adoption. And I think it was Darren who said it so well, right? It was the physician adoption of the technologies was spectacular. And I mean, for us, we trained over 900 clinicians to really get onto technology very quickly, whether that was inpatient technology, virtual ICU technology. People who before waved a phone and told me that this was not a doctor. Now we're serving those same clinicians, and Steven Spielman reported to us in our facility that they believe that about 30% of their business will remain online. And again, business defined, whether it's remote monitoring, whether it is virtual visits, whether it's inpatient work. I mean, really a whole new utilization of the EMR. It's really, I think, I don't know if you're seeing the same thing at your place, Darren. It was really the turn in the physician community that was great.
Yeah, and to echo that, and Roy, maybe to go back to your question, I'm not sure what aging in home will look like sort of in the far future, but what I will offer up is that healthcare is about ands and not about ors. And I think what we definitely have learned from this, and maybe go back to sort of the concept of a silver lining, if there is such a thing, here is that we have new tools in our quiver now that will absolutely get used. I think the challenge for all of us and for other, healthcare delivery systems across the country is to make sure that we don't squander this, and that we make sure that, this new tool set gets wired in. There's absolutely help we need in terms of payment model reform and other regulatory reform. But I really do hope that, a panel like this a year from now could really talk about which pieces lasted and where they really ultimately stuck. And in the same way, we couldn't predict which technologies we would actually use during the COVID crisis, even though we threw a lot at it, but are now obvious in this presentation. I think a year from now, we'll have figured out a lot more of those pieces that are going to be, permanent and sort of involved in our sort of toolkit that we want to use going forward.
So there's a lot of questions coming in along those lines in terms of the application of these technologies in the home. Obvious reason we all were at home for most of the time. But maybe just to make sure that we're kind of asking the friction questions at the end to make sure that everybody's, is still awake. Is there a point in time where we think that the quality of healthcare that we deliver over technology is not only going to try to equate to what we do in person, but actually has the ability to go above what we can aspire for when we do in-person care? If we think about cancer patients who are at home, our ability to check up on them through technology fundamentally changes if we see them in their home rather than have to see them in the office. Is there a point where we will turn to say the practice of medicine with technology is actually better than the practice of medicine that is only physical?
I think it's a $1 million question without a $1 million answer. I think that, at least from our clinician, I think it was Amy who said, there's going to be bricks and mortar and there's going to be online. Yeah. And there's certain things that are going to be more appropriate for in-person, and there's certain things that are going to be more appropriate probably in the future and even currently for online. I think we're going to have to figure out here which is which. There's only so far that you're going to go in the near future on diagnosing a broken bone. You still have to get to an X-ray machine. And I don't think that your X-ray machines are going to attach to your iPhone here in a year, maybe in the next 10, maybe in the next 15, but I don't think we're Star Trek quite yet. But I think the other question is then which modalities will work for each of the needs of our patients, if that's fair. Is that a good way to say your bricks and mortar statement, Amy?
Yeah, but what I would also add to that is that, in to Roy's question, we've been working in chronic disease and using digital care for the last 5+ years. And the doctor I work with, Dr. Milani, has published papers demonstrating that digital care, remote care, virtual care for chronic disease hypertension is far superior to episodic in-person visits. And that's in part because in chronic conditions, at least, right, there's got to be a combination of behavior change along with medications and being on the appropriate medications. And, the model that we've created that is fully remote and can be accessed by anybody anywhere in our digital medicine program is superior clinically. It also has been shown for cost reductions as well. So I think that we are at that point, that there is that proof. I think we need to be able to have more support in the system to incentivize more models like that, because certainly in chronic conditions, whether it's cancer and where you need to keep in touch between visits, like we like to say in healthcare, but just as you're living your life, right? And you want to remain healthy, but you want to live your life and not be tethered around a doctor's schedule. You want to be able to have your own schedule and to be able to be empowered to be healthy. If we're really trying to get to a place of health and empowerment, then we need to really push to get there. And I think the data is there that it is that we can see better outcomes when we really rethink the care model.
And I think, Darren, to question you on this, I mean, it's not just doctor to patient. It's not just caregiver to patient in that digital way. It's the artificial intelligence. It's the bots. It's the everything that we're going to use in the future. All of that, those tools in the toolbox. And you guys are amazing at that.
Yeah, I thank you. And I think, you know, it's for us, we're really approaching this as an and the exciting part is where each one of these are going to get used. And so, Amy, the stuff that you guys are doing in regards to sort of chronic care management and the demonstrations that you've done, I think that will be interesting now is we never otherwise would have run this experiment against that core fee-for-service, especially post-surgical work. And now that we have, I think that we're going to have new areas that I think may have a more direct path to some of the financing for us to sort of figure out. And it'll be interesting to see which ones end up sticking. But again, I'm super optimistic that there's pieces of this that, you know, we'll be able to talk about a year from now that really were the everlasting pieces that, you know, we never look back on.
So I think it's fair to ask our friends at Health who are telling us that we're out of time and time flies to maybe get us back in a year and see, you know, whether this reimagination of healthcare has accelerated in the pace that we want it to accelerate. I think now we have someone that's going to bend our minds to make sure that we're at least pliable enough to do that. But I want to thank Amy and Darren and Roberto for an incredibly, you know, insightful conversation. So much more to talk about, but it's a very, very good way to start and understanding the silver lining of all of this. Looking forward to a very bright future. Thank you all for joining us, and we're handing this over back to our health folks.
Thank you so much, Roy, and to all of our panelists. If you'd like to join us in continuing the conversation, please join us on Twitter. And now I'd like to introduce our mind-blowing mind reader, Mark Tolan.
Hey, everybody. It's nice to be here. Let's see if I can get in and you guys can see me and hear me. Seems like we're working. And maybe the host can put me out. There we go. Hi, guys. Hi, Roberta. Hi, Roy. How's it going?
So far, so good. A little bit afraid of what you're going to do to us, but otherwise.
No, don't be afraid. Don't be afraid. I just want to mess with your mind for a little bit, a little distraction from everything that's going on. My name's Mark. I'm a mentalist mind reader. I'm in Chicago right now, which is where I'm based from. But the team asked me to come in and give something fun, a little virtual entertainment for you guys today. So thanks for sticking around and being my very willing participants. We'll give this a shot. Maybe I'll start with Roberta, and then Roy, I'll try something with you in a moment, if that's all right. Okay, so hi, Roberta. Nice to meet you virtually.
Nice to meet you.
Roberta, I have something for you, and it's this. It's inside of this little pouch here. It's a few things. First off, a little piece of paper, and then some coins. We'll get to the coins in a second, but for now, I'll leave the paper here so you can see it right there, and I'll set it here just so you can keep an eye on it. And all of our attendees tuning in today can see it as well. Additionally, let me point out what these coins are. It's a penny, a nickel, and a dime. This is really a psychological warm-up, Roberta, just so I kind of see how you think, get in sync a little bit. If this goes well, I'll take it next level. But sadly, we're not in person, or I would give you these. So imagine I reach through now and I hand you the penny, nickel, dime. You have them now. Perfect. I see you taking those. Perfect. Look over them. Imagine you have those coins, penny, nickel, dime. Decide, take a moment, decide, and hand me back two. Which two would you like to give me?
Do I tell you?
Yeah, you can say for everyone watching.
The penny and the dime.
The penny and the dime. Great. So I've got those. I'll give you one back. We'll continue this elimination, but which one do you want? You make the choice. Which one should I give you?
I'll take the dime.
The dime. Great. So you're leaving me with the penny. Fair?
Yep.
Okay. I take the penny. I give it a toss. I catch it. Flip it on my hand. Tell everyone, is it heads up or tails up?
Tails.
Tails. Would you like to change your mind?
No.
No. Okay. I know this feels random and weird, but those were your choices in this moment, yes?
Yes.
Okay, so the penny is tails up. You could have done any number of things, but that's where we ended. The penny is tails up. I'm sure you remember this. A little piece of paper inside here. I'll be nice and slow so everyone can see. A little piece of paper. I wrote you a message earlier, and it says, the penny will be
tails up.
That's
amazing.
yeah. That's not too bad. Yeah, that's amazing. That's good. That's not too bad. Okay, so a little psychological warm. That's really just more of a test on my end, you know, because I have to have minds to read in order to get in sync. So now that I kind of know what's happening, let me try something with you, Roy. And Roy, I might ask you, do you have maybe a pen and paper nearby that you could use?
Sure. Yeah.
Yeah, great. Okay, so Roy, in a second, I'll have you write something down and hold it up so everyone who's tuning in can see. But for now, let me grab my phone here and just make a little bit of a guess of something. I'm going to go to Google here, and I'm going to pull up something on Google that's secret for now, but it'll make sense in a second. So let me show you. There's Google. I'm going to search for something. Let's go with this today. Just let that load, and I'll leave it right here. So again, you can keep track of this. But I'm trying to make this exponentially more impressive than the coins. It's fun, but it's only 3 coins, right, Roberta? And it's, you know, it's a little game of chance. This is a little more exciting, Roy. What I want you to do is think of a famous person. Think of a famous person that everyone watching would know. Someone very well known, a celebrity, you know, that we would know. It could be a historical figure, an athlete, a musician, an actor, whatever you want. Do you have a famous person in mind?
I do.
Okay. Now, if you'd be so kind, change your mind to a different person. So now you know that you're thinking of someone that you didn't even know you were going to think of, right? This is a brand new random thought, but make sure it's someone super famous. It can't be someone that you're into, but that I wouldn't know. It's got to be someone famous. Do you have a person in mind?
I do.
Okay. Write their name down nice and big so you can hold it up and show everyone.
Both of them.
No, just the last one, whatever you ended up on, that final one. That's your choice. Go with that person. And hold that up so everyone can see. To everyone tuning in, the reason I have Roy hold this up is because I don't want you to think this is voice activated. Usually, in different circumstances, I would take Roy's phone and do it with your phone. But since we're like this, we'll do it in reverse. So, Roy, hold that up, but don't say it. Just show everyone. Perfect. Okay, everyone can see. I'm not going to say the name, but everyone knows now, and the group of us all watching know the person you're thinking of. Now, Roy, that's not the first person you thought of, right? It took you a jump to get there?
True.
Yeah, fantastic. Okay. Well, Roy, you will see, if I can unlock my phone here so you can see, you will see that that is exactly who I searched for. That's Frank Sinatra right there.
Yeah, that is pretty scary stuff.
Pretty scary. Yeah, I would say so. I would say. I'm sure you agree, that's a little more impressive than just 3 coins or something like that.
Well, knowing what money is very usful, don't get me wrong, but it's very impressive.
No, that's good. So let's do a quick thing that everyone watching and you guys can do, which is it's really a psychological thing. And now that everyone's seen this, it might work with, 80, 90%. We'll see how it goes. But it uses just a few cards, because one of the questions I get asked often is, can you use this in any way? The answer is yes, playing cards obviously is a good real world skill. So in a second, I'll turn these cards around. Roy and Roberto, you both can look at them and do this. Everyone tuning in can do this wherever you are. Just see one of the cards and think of it, right? See one, think of it, perfect. Okay, these cards were arranged in a way that hopefully makes one of the cards more psychologically appealing than the other. So I am hoping that even though you could have thought of any card, that you all went for the card I had in mind. And I've just taken it out. If that worked and you fell for it, just give me a thumbs up on the screen if I got your cards, maybe. You can, and then we got Roberto still. Okay, so it worked for you guys. If you're watching and it worked, I'm getting some hands raised over in the side, which means it worked for those people as well. There goes some more hands. Oh, that's fantastic. So it doesn't necessarily work with everyone, but the hands are going up very quickly, which means we are all kind of in sync. Fantastic. So Roberta, I just met you, but it's very nice to meet you. Where are you right now? Where are you from?
Houston, Texas.
Oh, you're in Houston. I've got family down there. Fantastic. I'm in Chicago, so let's do something long distance. Could you think of, I think this will interest you, a memory that is special to you in some way? So it could be from 2 months ago, it could be from 2 years, 20 years ago, it doesn't matter, but think of some kind of memory that jumps out. And you don't have to go for the biggest thing in the world. It could be something simple like a walk in the park. you know, sitting on the porch with friends. It could be something very personal. That's what makes memories so fun. So could you think of something special like that?
Sure.
Okay, good. Can you associate a time with that, like hours and minutes? I know it's a random question, but like I was born at 8:45 a.m., so that'd be a time. Or I always remember my dad would come home from work at 5:30 and would get excited because it was time to play basketball with him or something like that, right? So if you can kind of create a time around it, even if you have to kind of make it up in some way, and it's a little abstract, that's fine. But could you come up with hours and minutes?
Sure.
Okay. Now here's my question. If you tell me the memory, would it give away what time you're thinking of?
No.
Okay, good. Because, you know, if you said getting out of school, that'd be 3 p.m. or 3:15 or something, right? So this is good. So if you tell me the memory, I will try to guess the time.
Okay.
Okay, so what memory were you thinking? What's this special memory?
Running with my daughter.
Running with your daughter. You're a runner too. I'm a runner as well. I want to do the Houston Marathon, speaking of. So running with your daughter. Okay, so you have a time in mind. This could be, I don't know if you're a morning runner or evening, or if this is a race or something casual. Okay. Okay, imagine that time like you were going to send it to me. I'll do my best here. Okay. I'm going to change my, I'll show you, it's not there yet, but I'm going to change my my watch to a time here. Okay, I'll commit to that. I'll commit to that. Before I show you, would you tell everyone who's watching, what time did you put with this? You know, it could have been any number of things, I'm guessing, but what was the hours and minutes?
7:30 at night for about an hour.
7:30. Oh, okay. So you went out for a decent number of miles. 7:30 at night, and that's just something that you had in mind right now and created, right? We didn't talk about this beforehand.
Right.
Hopefully you can see that. But that is exactly what I went with. 7:30 at night. Fantastic. That's 7:30. Yeah, that's pretty good. I like running in the evenings too. Now, Roy and Roberta, I'm sure you both noticed this little envelope over here. Roberta, did you go through a few memories in your mind, or was that kind of just the first one you went with and you stuck with it?
A few memories.
You did. Okay, so everyone who's watching knows that this was something that you thought of right now. And since you changed your mind a few times, it makes it really spectacular. This envelope has been sitting in plain sight the whole time. And I wrote a little message on it before I came on. I think you will find this interesting. It says,
Wow, running with my daughter. Very impressive.
very impressive. That's pretty good. That's pretty good.
Are you going to share
Wow.
how you do this?
Unfortunately, it's more of a performance and less of a Q&A session, but
Got it.
yeah.
I'm
As the
ready to
moderator,
get off the line before you figure out a few other things that I don't want you to know.
No, your secrets are safe. I promise. I promise. Roy, we got time for one more. So can I try one more with you? Would that be all right?
I'm afraid to say yes, but yes.
No. Let's just take this next level, and we'll just go all the way with this. So Roy, are you watching on your phone today, or a tablet or computer? How are you tuning in? Computer. Okay. Do you have your phone nearby?
Yeah.
You do. Pull your phone out and go to Google for me, if you wouldn't mind. You do that. I'll grab a couple of this. While you're pulling up Google, big shout out to Health for having me today. Like I said, my name is Mark Tullen, but I'm just excited to be here and be able, I'm sure like many of you, to find ways to work from home and keep doing what I love to do, which is put smiles on people's faces and bring a little joy in difficult times. So, Roy, you got your phone? So yeah, thanks to Health for having me today. Roy, when you get to Google, would you search for this? I'll just go all the way with this, which is the hardest thing I know how to do. Search for how many articles are there on Wikipedia. And I'm gonna get my calculator here. I'm gonna total this so everyone knows and is aware of what we're working with.
Yep.
So when you have that, there's a website I like to use sometimes. It's called wikicount.net. Did that come up maybe in your searches? Do you see that maybe?
It actually came Wikipedia.
If you find, maybe hold your phone up. Could I see if you hold it up towards the camera? Let's see what we're dealing with here.
Can you see this?
Oh yeah, if you scroll down a little bit, Again, a text there. But yeah, if you scroll down, I think wikicount.net was down below that, maybe one or two. Hard to see through the camera, but that's okay. This is, or you can type it in maybe, wikicount.net. This is a good site to use because it is updating all the time, because Wikipedia is updated by people like you and me to keep it current, to keep it, you know, as fresh as possible as things happen. So when you have that, hold that up so everyone can see maybe what you're dealing with. Oh, there we go. So see, this number is perfect. Okay. So what does that say down below? The number of words per article is at 1329. Okay, so 1329. And if you wouldn't mind, hold that up one more time so I can see that. And then, okay, 6097, 813 equals. So if we put those two numbers together, we get a big number here, which is the average number of words times average number of articles, which is approximately how many words there are on Wikipedia. 8.1, it's quite a big number, 8.1 billion. So Roy, hit visit Wikipedia, and then show everyone when it loads that you've made it to Wikipedia. Fantastic. Okay, now Roy, I want you to hit the magnifying glass up there and search for something from your own life. It could be a person, a place, a thing. It doesn't matter what this is, but search for something from your own life that is important to you. This time, do not hold it up. So don't go maybe for Sinatra, because we had that earlier, but it could be a celebrity. It could be a location. Don't do Houston, even though it's a lovely place. You know, do something like that. Do you have something that you've pulled up?
I do.
Okay, so scroll down the article for me without showing us. Make it random. Stop anywhere you want. And then look for a random long word in the article. 10 letters or more, maybe. Something pretty long. Do you have a random word? Don't say it, but something not even connected to what you searched for, maybe.
Sure.
Okay, put the phone like this so everyone knows we're fair and you can't change your mind. Yeah, just put the phone against you like this. Very good. Okay, so I will do my best to work this out. When you picture this big word in front of you like a billboard, right? So you see it here, and imagine saying the word over and over and over. And then just think of okay, good, a longer word. Okay, and then think of the first letter like you're going to say it, just the first letter. Is that an R?
No.
No. Okay, maybe there was something else that went in your mind. Or what is the first letter of that
T.
random word? What is it? T?
T. Yeah.
T. Okay, that's there is an R near the beginning, maybe.
Yes.
Yeah. Okay. Yeah. Yeah. Okay. Okay. We're kind of there. So just go the next. Okay. I'll go with. I was just trying to work that out and just trying to figure out where that was. Okay. I'll go with something like this. Remember, there's over 8 billion words. You could have thought of any word. Would you tell everyone? Don't even show us. Just keep that hidden for a second. What was that word you thought of? What's the word? The random word.
Throughout.
Throughout.
No way.
That's pretty good.
Wow.
Roy, are you thinking of something that the thing you search for, is it from your own life or is it completely random?
No, it's my own life. Yeah.
Okay. I think you thought of a location. Am I right? Because you already thought of a person earlier, so you go for a place, yeah?
Yep.
Yeah. And you would go, not in America, somewhere else.
No, it's in America.
Did you think of somewhere outside of the country and then change?
No.
No. I know what it is. Sorry. I'll go with this. Tell me. What did you search for?
I searched for the island of Nantucket.
Nantucket. Very good. Very good.
Okay, this is the part where I turn my camera off so that I can go.
Me too. That's
I mean,
that's all the time I have today. But Roy and Roberto, thank you guys so much for participating and helping. I'm glad you guys are safe. And again, big shout out to Health for having me, and to all you watching. Hope you enjoyed. Thanks a lot, guys. Appreciate you both.
that's terrific.
Bye. Thank you.
Thank you, Mark, and thanks to everyone for joining us today. Please enjoy the rest of your day.